Okay, so good morning everyone. Today we will continue our presentation on the neuroradiology chapter of the core review with Dr. Shino. She will talk to us about orbital pathologies.
Thank you. Good morning. Today I would like to talk a few notes about the orbital pathology and facial spaces and a few points about the cervical lymph nodes. First of all, a few points about the orbital anatomy. We have the bony orbit. This is a pyramidal shape with the apex pointed posterior medially and is composed of the five bones: frontal, ethmoidal, lacrimal, maxillary, and zygomatic bone. We have in its apex the orbital, the optic foramina, which contain the optic nerve and ophthalmic artery. Also, near to it, in between the greater wing of the sphenoid and lesser wing of the sphenoid, we have a fissure called superior orbital fissure, and this transmits many structures like cranial nerve, third cranial nerve, oculomotor, trochlear, first divisions of the maxillary nerve, which is the ophthalmic branch, and superior ophthalmic vein. Inferior orbital fissures located between the greater wing of the sphenoid and the palatine with the maxillary portions of the orbit. And this is covered by the tuft periosteum that allow the orbit to be not affected by the fracture sometimes. It maintains the integrity of the orbit. Compartment of the orbit. Here we have septum, thin septums that divide the orbit into the preseptal and postseptal compartment. The preseptal compartment located anterior to the septum, which is a thin connective tissue connecting the margins of the orbit to the tarsus of the eyelid. The preseptal portion of it is potential space and does not contain any orbital structures. Postseptal orbit, which is located posterior to this part, it's divided into extraconal, conal, intraconal, and globe. The extraconal compartment is composed of the bony orbit, lacrimal gland with the fat. Conal, it's composed of the extraocular muscles. Intraconal, fat, lymph node, and the nerve, optic nerve with the sheath and sensory and motor nerves of the orbit, and the globe as a distinct compartment. First, we have a topic of infection. The infections is most commonly arise from the infections of the paranasal sinuses, or from the trauma or foreign body, or from the tooth, for example, infection of the odontogenic infection. Orbital cellulitis, phlegmon. Here, there's infections with the orbital that does not organized or ring enhancing. This is important. Why? Because it may extend intracranially via the ophthalmic vein. Here is the two axial sections of the orbit and brain, anterior part of the brain, showing complete opacifications of the frontal of the ethmoidal and sphenoid sinus with and there is two air in the anterior to the extra-axial compartment posterior to the frontal sinuses, and this is the
It's intracranial extension
of the cellulitis.
Yes. So the important thing here is there is no abscess, there is no wall.
Yes, there is no.
Just
it's less severe than that.
It's just soft tissue edema and infection and discology.
Yes. Suprahyoid abscess here is the organized one, this one. Yeah. And this lead to the exophthalmos and visual impairment. And the risk of this is lead to the permanent blindness. So it's the surgical emergency and should be either drench or give the intravenous antibiotic. Orbital abscess, it's more severe form of the infection and lead to the clinical presentation of thermoplegia and symptoms of the supraosteal abscess. We should think about the cavernous sinus thrombosis if we have abscess, if there's multiple cranial nerve pulses. So if we see the multiple cranial nerve pulses with symptom of the orbital abscess, we should think about the cavernous sinus thrombosis, which is the severest complications of the infection. Orbital masses, intra and extra conal, excluding optic nerve sheath. We have hemangioma. Hemangioma, we have orbital cavernous hemangioma and capillary. Cavernous hemangioma most commonly occur in the adult and is usually intraconal, but maybe extraconal. It's composed of the vascular channel filled with the slowly moving blood. So in CT scan, there is ovoid enhancing intraconal or extraconal mass. Bony remodeling may be present also. On MRI, there's a well-defined mass, iso intense on T1 and hyper on T2, early patchy enhancement that progressively fill in. Here, this is the MRI axial section, T1 post-contrast, showing heterogeneous enhancement. It's not filled in completely. There's some area.
Like any hemangioma anywhere.
Yes.
It's peripheral enhancement towards the center.
Yes, toward the center. Capillary hemangioma is most commonly in the pediatric age group associated with a skin lesion, such as port wine strain and strawberry hemangioma. Capillary hemangioma typically enlarge over time, over time, and then regress spontaneously. This is the pictures of the hemangioma on CT.
So all you
Capillary.
need to do is follow it up.
Yes,
Like
no
this,
need
otherwise.
treatment. Yes, it's regress by itself. Orbital lymphoma. Orbital lymphoma, here we have the lacrimal gland is the most common site. It's present with the painless downward proptosis. Painless. CT is hyper dense in CT, but in MRI it's hypo in T1 and T2 because it's hypercellular tumor. Orbital lymphoma and orbital pseudo tumor both tend to mold the globe. They mold it. It's not invaded.
It does not invade, does not destruct, it's just infiltrate
Just,
between
yes.
the muscles and the nerves and the things.
Yes.
You know?
Here two pictures are coronal and axial sections of the CT, showing the soft tissue mass in the superior lateral aspect of the orbit, hyperdense lesion. And we cannot differentiate between the mass and the lacrimal gland, so it may arise from it, and it's a picture of lymphoma. Lymphangioma is the benign hamartomatous lesions. On imaging, it appears as the multilocular cystic lesions, sometimes air fluid level or complex internal echo. We can see on it. On enhancement, there may be septal enhancement or slight peripheral enhancement. These are pictures of lymphangioma. Schwannoma and neurofibroma. The schwannoma is more common, affect mostly the sensory branch of the first branch of the trigeminal nerve, ophthalmic branch. So its location is important. It's located superiorly. The nerve which is involved eccentrically, not central, eccentrically. MRI is hypointense on T1, hyper on T2, and demonstrate enhancement. Here is the T2, which is slightly heterogeneous here, and this is the T1 fat sat post-contrast.
Yep.
Demonstrate enhancement.
Light bulb.
Yes. Metastasis to the orbit in the adult is most commonly from the breast, lung, thyroid, renal cell carcinoma, and melanoma. In the children is metastatic neuroblastoma, classically cause aggressive sunburst type of the periosteal reaction within the involved bone. Here also the coronal and axial section demonstrates soft tissue mass, and we cannot differentiate the optic nerve. We cannot differentiate the optic nerve clearly, and the muscle, the in middle and inferior recti muscle. Medial. Yes. Medial. Sorry. Lacrimal gland lesions. We have the lacrimal gland is composed of the epithelial salivary tissue and lymphoid tissue. So the diseases that affect the salivary tissue and the lymphoid tissue also affect the lacrimal gland. In the epithelial tumors of the lacrimal gland, either benign or malignant. 50% are benign, like pleomorphic adenoma. 50% are malignant. Example, adenocystic and mucoepidermoid carcinoma. Disease of the lymphoid tissue such as sarcoids, lymph, and lymphoma. Also, the lacrimal gland is the most common site, as we say, for orbital lymphoma, and may become enlarged in the case of orbital pseudo tumor. Extraocular muscle disorder, conal. We have thyroid ophthalmopathy, thyroid eye disease. Graves' disease is the most common disease, or any thyroid disorder may affect the eye. First, there is increase in thyroid ophthalmopathy, first things there's proliferations of the fat. Yeah, there's increase in the intraorbital fat. Then later on, extraocular muscle become enlarged in this order. First, inferior rectus, medial rectus, superior oblique, lateral oblique. The isolated lateral rectus. Sorry, this lateral rectus. Isolated lateral rectus enlargement is very uncommon.
Inferior, medial, superior oblique, lateral rectus?
Lateral rectus.
Okay.
Yes.
So the last one to be involved is the
lateral rectus.
So
if lateral is,
rectus,
we should diagnose other causes,
okay,
and there may be other causes for this. It's
one
very
to be
rare.
involved,
Also, the thyroid ophthalmopathy, it's bilateral and sparing the muscle tendon. Here,
And the first is the inferior rectus.
inferior rectus, yes. First of all, there's increase in the fat. Here, there's professions of the fat with some proptosis of both eye. We can know, we measure this from here to here. We make a line. There should 1/3 of the orbit behind this line.
The globe.
The globe, yes.
One
The
third
globe.
of the
1/3 of the
globe.
globe. If it's outside it, it's exophthalmos. And also we say that it's bilateral and spare the muscle tendon. It's important to differentiate it from the other causes. Orbital pseudo tumor is idiopathic bilateral inflammation. Clinical feature is painful proptosis. Painful proptosis. In lymphoma, it's painless. Here, it's painful. And diagnosis is the diagnosis of the exclusion. The lacrimal gland also is the most common site of the involvement. If involved, the anterior structures produce uveitis. On imaging finding, there is stranding within the orbital fat, increasing the orbital soft tissue, enlargement of extraocular muscles.
And reach the tendon of the muscle.
Yes, it's involved the tendon. Yes. Optic nerve sheath disorder, intraconal. Optic nerve glioma is the most common tumor that arises from the optic nerve sheath complex. In the childhood is the slow-growing astrocytoma with an indolent course and better prognosis. Variable MRI appearance appear as a fusiform enlargement of the optic nerve and variable enhancement, as we said, associated with the neurofibromatosis type 1, often bilateral. Optic nerve glioma of the adult is usually anaplastic astrocytoma or glioblastoma multiforme with a poor prognosis. It appears as an enhancing mass, in this case, enhancing mass that extend intracranially to involve the optic chiasm and may involve the optic radiation. Here, this is the T1 post-contrast. This is the T2. This is the T2 also coronal. Here there is no enhancement of the fusiform enlargement of the anterior part of the right optic nerve with no enhancement, showing no enhancement. This is hypo in T1 and hyper in T2. Optic nerve meningioma. This also, like the other meningioma, is occurring in the middle-aged female with a slow progressive visual impairment and progressive central visual preservations of the central visual field. On imaging, the nerve sheath circumferentially thicken with uniform contrast enhancement. Enhancing here, if we give the patient's contrast, there may be enhancement of the optic nerve sheath with preservations of the optic nerve and giving the rise to the tram track sign on axial image.
So if you see tram track sign in the optic nerve,
Is
it
that-
means there is a meningioma.
Yes.
Another يعني points for differentiate between the optic nerve meningioma and glioma. The tortuosity of the nerve goes with optic nerve glioma. Second, classification. If we see the classification, it goes with meningioma.
Meningiomas.
Yeah,
A third enhancement, as Dr. Rashid said, enhancement of the optic nerve meningioma, while glioma there is minimal or no
No
enhancement.
enhancement. Yes, thank you. Opticneuritis is not specific inflammations of the optic nerve. It's painful and present with a painful subacute vision loss and reduced color perception. The causes may be multiple sclerosis, viral infection, sarcoidosis, vasculitis, and toxin exposure. If we have optic neuritis with spinal demyelination, it's called the Davik syndrome. Acutely, the optic nerve, there's enlargement of the optic nerve. If there's enhancement, it indicates active disease. In chronic disease, there is atrophy. Imaging of the brain and spinal cords are important because to evaluate for the intracranial plaque. Here,
It's a part of multiple sclerosis.
yes, here there is the MS plaque in the brain in the periventricular area, and here there is the enlargement of the optic nerve with enhancement on the, and we cannot differentiate the CSF surrounding it from the optic nerve. Globe, we have retinoblastoma. This is the most common primary malignant tumor of the globe. Is almost always seen in the children under 5 years of age. With clinical features, leukorrhea, white papillary reflex. It may be sporadic unilateral or familial bilateral. Classically, it appears as a hyperattenuating, enhancing retinal mass with calcifications in a normal size globe. We have trilateral retinoblastoma, that's bilateral retinoblastoma زائدا pineal gland pineoblastoma, or quadrilateral, that's bilateral retinoblastoma, pineoblastoma, and supracellular retinoblastoma. Here, the axial sections of the CT showing hyperattenuations of the globe with the hyperattenuation mass like in the retina. This mass is calcified, and this is the retinoblastoma. The size of the globes are normal.
This is the retinoblastoma image.
One is calcification in the retina.
I don't think so.
Drossen.
It's like a drusen more than a retinoblastoma. Check the image. From
I checked in the internet. I bring it.
I don't know.
Yes,
Well,
it's look like Drossen. Yes.
It's like
Yes.
drusen, rather. This is an adult skull. It's not a child. Anyway, no problem.
Okay.
Why this image is not retinoblastoma?
Retinoblastoma should be a mass. This is calcification within the globe. There is no mass. First. Second, it should be a child. The bone calcification pattern, you can see this is an adult. I don't think there should be mass aggressive, invading, destructing, enhancing, and blah blah blah. It's just a spot of calcification on the globe, so it's more favor of drusen rather than. But anyway.
Okay. Retinopathy of the prematurity, it's only occur in the premature infant due to the prolonged exposure to the oxygen, يعني oxygen therapy. Both eyes tend to be affected equally. There is bilateral microphthalmia, يعني small globes, with the increased attenuation of the globe due to the prior hemorrhage. Intracranial calcifications may be present also, and this distinguished from the retinoblastoma by microphthalmia, يعني the small globes. In the retinoblastoma, the globe size is normal. Late complication lead to the shrunken, non-functioning globe, which is called the phthisis bulbi. Phthisis bulbi. Here also, the globes are small with hyperattenuation, and multiple calcifications here are seen. Persistent hyperplastic primary vitreous is a persistent embryonic vasculature within the vitreous that it causes loss of the vision from the hemorrhage, cataract, and retinal detachment. It affects the full term. Also, there is a small microphthalmia with increased attenuation, but here there is no calcification here in this case. Colobuma, this is the elongated or malformed globe associated with the numerous syndrome like trisomy 13, 18, and Charge and Vater association. Imaging shows a cone-shaped or binotched shaped deformity. Optic nerve colobuma can have the outpouching either posteriorly or anteriorly. Posteriorly if affect the optic nerve, and anteriorly if affect the uvea. The iris. If involve the uvea, tend to have the microphthalmia and cyst.
So coloboma can arise from the posterior aspect of the globe, from
Or
the optic
it's
nerve,
like a diverticular
or, exactly, or from anteriorly affecting the iris.
iris, yes.
And if it's anterior and it's affecting the
Uvea tend to have them,
part,
yes.
it will tend to have what?
Microphthalmia and cyst. Congenital orbital lesion, we have the sphenoid wing dysplasia. This seen in the neurofibromatosis type 1 lead to the pulsatile exophthalmos. Here in this picture, in this CT axial section, we see there is absence of the sphenoid wing and proptosis, unilateral proptosis. Septo-optic dysplasia is optic nerve dysplasia plus agenesis of the septum pellucidum, often associated with the schizencephaly. Here, there is hyperplasia of the optic nerve and schizencephaly and absence of the septum pellucidum. Another topic is the facial spaces of the suprahyoid neck. We have many spaces that we have spaces infrahyoid also, but facial we discuss only the suprahyoid neck. It's the complex layers of the cervical fascia produce several facially bounded spaces in the suprahyoid neck. The pharynx is the most important structures here in the head and neck. This is surrounded by the many spaces. The spaces are surrounding it. We have a nasopharynx, oropharynx, oral cavity, and hypopharynx with larynx. The nasopharynx is located posterior to the nasal cavity till the level of the heart palate. The oropharynx extends from the heart palate to the level of the hyoid bone and involve the posterior 1/3 of the tongue. The hypopharynx extends from the hyoid bone to the esophagus posteriorly. Oral cavity is bounded superiorly by the heart palate and inferiorly by the floor of the mouth, and it's the anterior 2/3 of the tongue is included in the oral cavity. The larynx is extended from the hyoid bone to the tracheal ring anteriorly. We have spaces. These spaces are important to add the differential diagnosis of the disease and to make the differentiation between the disease easier. We have masticator space that's located anterior to the parotid gland. And this space contains the muscle of the mastication like masticator, temporalis, internal trigoid, and lateral trigoid muscle with the mandible. The differential and it's contained the cranial nerve, the mandibular branch of the trigeminal nerve. Differential diagnosis of the masticator space lesions, either odontogenic, example dental disease that may lead to the abscess in this area, or mandibular lesion like osteosarcoma and metastasis, or from the muscle like rhabdomyosarcoma. Carotid space, also called post-styloid parapharyngeal space. It extends from the skull base to the aortic arch, and the contents are here, this is the carotid space, and the contents are internal carotid artery, carotid body, jugular vein, and several cranial nerves. The vagus nerve, it's located in the full length in this, yes. And the other one, like the glossopharyngeal nerve and the spinal axillary-hypoglossal, are intermittently, transiently pass through it. Differential diagnosis of the carotid space mass, we have paraganglioma, schwannoma, and neurofibroma. Paraganglioma MRI appearance, there's intense enhancement, characteristic salt and pepper appearance due to intratumoral flow void. Paraganglioma of the carotid body lead to the splaying of the external and internal carotid arteries at the aortic, at the carotid bifurcations, while the paraganglioma of the vagus nerve, glomus vagali, displays the internal and external carotid artery anteromedially.
So if they are splayed
in the carotid body tumor, yes.
Pushed,
this vagus nerve, vagal nerve, glomus vagali. Schwannoma also displays the carotid artery anteromedially. It's not, we can differentiate it from the paraganglioma that it's not nearly as vascular as it and does not enhance homogeneously. And this cannot be differentiated by imaging from the neurofibroma, but neurofibroma associated with the neurofibromatosis type 1. Parapharyngeal space, this is the triangular fat filled space here. This is the potential space, and it's important to know it because it's placed by the pathology by nearby spaces. For example, if you have a masseter space, like if there's an abscess or something, or mass or something like that, displace it posteromedially. If we have a mass in the parotid gland, like pleomorphic adenoma, displace it anteromedially. If you have mass in the carotid, like carotid body tumor or paragang or anything, that space is anteriorly. So it's important to know this, and this space is potential space, only contain fat or some minor salivary glands. Perivertebral space, it's formed by the deep layers of the deep cervical fascia that wrap entirely around the perivertebral and paraspinal muscle. The content is the vertebral artery, vertebral body, and spinal canal, paraspinal muscle, and exiting nerve. Last subject is about cervical lymph nodes, and these levels, we have 7 levels. These are defined by anatomical landmarks and organized by pattern of the lymphatic spread. And these lymph nodes are important because many tumors of the head and neck are of squamous cell carcinoma and metastasize to the lymph node. And these lymph nodes are important to know it because it has a prognostic value and it affects the staging of the disease. Here are some landmarks. We have this is the mandible. This is the submandibular gland, and this is the anterior belly of the digastric. This is the posterior belly. This is internal carotid, and this is the internal jugular vein. This is the sternocleidomastoid, and this is the trapezius muscle, thyroid, cricoid, and this is the hyoid bone, and this is the trachea. These are some landmarks. Level 1, we have levels of the lymph node. Level 1, this called the submandibular level. It divides into A and B. The A is located in between the or medial to the anterior belly of the digastric. The B is located posterior to the anterior belly of the digastric and extend to posterior to the submandibular gland, and inferiorly it's bounded by is located at the upper surface of the hyoid bone. Level 2, it's called superior jugular. Superior jugular is located, extend from the base of the skull to the inferior margins of the hyoid bone, and it's divided anterior into the 2A, which is located anterior to the posterior margins of the internal jugular, and B is posterior to it and bounded posteriorly by the posterior aspect of the sternocleidomastoid. Level 3, it's called the middle jugular level. That's extend from the inferior margins of the hyoid bone till the cricoid cartilage, and also bound posteriorly by the posterior margins of the sternocleidomastoid. Level 4, it's called the inferior jugular, and this is located, and this is extend from the inferior margins of the cricoid cartilage to the clavicle. And posteriorly, upper part of it is bounded by the posterior parts of the sternocleidomastoid, and the inferior portions of it by the posterior margins of the anterior scalenus muscle. Level 5 is extend from the base of the skull till the clavicle, and this is called the posterior cervical lymph node levels, and these divide into the superior and inferior according to the undivided at the level of the cricoid cartilage. This level is divided into the superior and inferior, and is bounded posteriorly by the trapezius muscle. Also, we have another levels called anterior tracheal. That's the group 6, anterior tracheal, and located below the hyoid, below the cricoid, till the upper portions of the manubrium sterni. Another one, level 7, which is the last one, called superior mediastinal level, and this from the upper parts of the manubrium sterni till the brachiocephalic vein. Thank you.
Thank you very much.
لا شكرا. Thanks.
Any question? Any comment?